Hi, everybody. Thank you for joining us for this webinar. I would like to introduce Dr. Bengs to everyone. We thank him tonight for joining us for this important lecture about joint health. Dr. Bengs has been with Providence St. John's and the Center for Hip and Knee Replacement since 2018. He's currently our Director of Special Surgery. And before joining St. John's, he was the Chief of Joint Replacement Surgery and Department Vice Chair at UCLA, where he was also an Associate Professor of Orthopedic Surgery for 10 years. He received his undergrad degree from UCSB up in Santa Barbara and graduated from Georgetown University School of Medicine with cum laude and Alpha Omega Alpha distinctions. He completed orthopedic surgery residence at Harvard and was awarded the Leonard Marmor Award for Excellence. He's a smart guy. Dr. Bengs then completed an additional year of joint replacement fellowship training at UCLA. For 15 years, he specialized in joint replacement, fractures around the joints, and complex joint surgery, such as revision joint replacements. He's a board certified and fellow of the American Academy of Orthopedic Surgeons. And when he's not helping our patients get back to moving and enjoying life, you'll find him on his ranch in Paso Robles. And I'm guessing that may involve a couple glasses of red wine, which is good for your heart health. And he and his wife, Meg, love sailing. And they've recently discovered a new passion where they make pizzas from scratch. So they've got their pizza stone and they make their dough and their sauce. And I bet pizza and red wine are pretty good in the Bengs household. Meg apparently is at the helm on the pizza cooking, and Dr. Bengs is the sous chef, and their cat Critter is an observer. So without further ado, I'd like to introduce Dr. Bengs to you. Dr. Bengs, you're on.
Hi, thank you, Connie. That's very nice of you. Can you hear me okay?
Yes, we can.
Good, okay. Well, let me just share my screen. It's a very, very kind introduction. Thank you very much.
Mm-hmm.
So I'm going to share my screen. And
while you're doing that, Dr. Bengs, one more point of housekeeping.
Yeah.
There is a question and answer function and a chat function. So if you do have questions, you can put them in, and then we'll either answer them along the way or maybe after the conclusion of this presentation.
Sounds great. Let's see, share screen, my presentation. Zoom sharing. It works so easy when we're.
I know, it was there. I'm seeing a wide. Oh, there it is.
There we go. From beginning, and I'll try to keep my eyes open for any questions, but I'll try to address most questions with the presentation. So good evening, everybody. I'm Benjamin Bengs. I hope you can hear me okay. Connie gave a very nice introduction. Tonight we're going to talk about joint replacement surgery, arthritis, and then have hopefully time to answer any questions as well. So I made this presentation, the beginning slide, a few months ago in the middle of the pandemic. And back then I thought it was important to have a reflection before starting off on presentations. And my reflection today is basically that everything is going to be fine. Now, this was in the middle of the pandemic, so I was trying to be positive here, but still it's worthwhile saying everything's going to be fine. We're still going to ride bikes with my lovely wife there. The sun will still shine and warm our planet. We're going to have trees and rains and weather. Humans will be born, live, and pass. Sunsets will happen. Conflicts and resolutions and failures and triumphs will come and go. Life will never be perfect, but at least it's interesting. And yeah, that makes me feel pretty good. So I hope it passes on to you a little bit tonight. So joint replacement. I'll do a brief introduction to myself, although Connie's already done that nicely. We'll talk a little about joint disease and arthritis. We'll talk about non-operative treatment for joint disease. And then, as most of you are interested, probably primarily into the operative treatment for joint disease. We'll touch on some of the newer technologies and issues in joint replacement today. And I think it'd be remiss of me not to at least address some of the concerns for complications, as even though we take joint replacement as somewhat of a perfected surgery, there are complications occasionally. And I think consumers and patients should know that. I'll try to answer some frequently asked questions. And if there's time and Connie allows us, we'll have some direct questions. So as Connie said, I'll go through this since I think Connie touched on this nicely. I'm the Director of Special Surgery at St. John's, which means I do joint replacement surgery, but I also do a lot of more complicated things, previously done surgeries, revision surgeries, kind of complicated deformity things. I find it intellectually very gratifying, but I also do just regular joint replacements. I did go to UC Santa Barbara, then Georgetown, then Harvard. You can see this is my street in Boston. My car's somewhere buried in the snow. I went up to UCLA, and this is my new view from UCLA. Not really from UCLA, but that's from Malibu. I was a professor there and did pretty well. I had a good time there. I really enjoyed UCLA, but now I'm here at St. John's in this beautiful hospital, and I'm very happy to be here. I thought some of you might enjoy some pictures of our team and some of the things that you see in surgery. So this is just a typical view of the operating room. This is a patient who's draped. You can see the knee there, and the tech is there wrapping things up very securely and very sterilely. We all wear those hoods to prevent infections. That's some of the scenery you see inside joint replacement surgeries. This is our wonderful nurse practitioner, Andrea. I should have taken her mask off, but she's a wonderful person, and I love working with her. My fantastic partner, Andy Young, and his beautiful wife and daughter, and his son didn't make it into the slideshow. I'm sorry about that. This is some of our team at the Checker Center for Hip and Knee Replacement. Some of our secretaries and bosses and teammates, and they're a great team. More folks in surgery, some of our circulating nurses, the anesthesiologist who didn't want to be part of the presentation, so he turned around, and of course my cat who helped apparently with the presentation. Well, she likes to pretend that she helps with the presentation. So arthritis. So arthritis and joint disease has been around ever since man has walked on two legs, maybe even before that. Other than canes and walking assistive devices, there's really no treatment until modernity, and I'll call that around 1800s. Early surgical treatments were somewhat barbaric by modern standards. You could cut the joint out, you could cut the muscles around the joint. Well, you could amputate. That's not really a modern day idea of a successful outcome, but those were the things that we had back in the day. 1 in 5 Americans are affected by arthritis. I'd say it's actually more than that. I think it's growing every year. Any joint can be involved with arthritis and with joint disease, but typically it's the weight-bearing joints. That's typically the hip and knee. The pain is often described as deep, diffuse, persistent, progressive, and it's often associated with stiffness, and it kind of creeps up on you. A lot of patients tell me that, there was no turning point. It just kind of crept up on them, and month after month they went through this pain and this stiffness, and all of a sudden they felt they were just too healthy to be this inactive. The cause of arthritis is not known really, even though it sounds like an inflammatory condition. It's actually more of a degenerative condition. There's some association with the weight of patients, and obese patients do have higher rates of arthritis, but it's a weak association. There's some childhood developmental disease that can contribute to arthritis, such as malformations of the hip as a child, or knee for that matter. As the joints degenerate, there's often a sense of instability or maltracking. Sometimes people just don't feel right. I saw a patient today, a very nice lady. She wasn't really complaining of pain. She was mostly complaining of a knee that just didn't do what she wanted to do. She tried to walk and it just didn't go straight. And it was an interesting manifestation of arthritis. Knees can become crooked or fixed in flexion, also a very common finding. Oftentimes patients don't even notice it. It's such a slow progression. Hips can cause limping and inability to put on shoes or get up from a chair position. It just hurts in the groin. Hurts in the groin, hurts in the buttock. It's a typical presentation for hip arthritis. The stairs are a common difficulty for patients. Stairs are pretty high demand for hips and knees, and patients find themselves oftentimes struggling to go up or down stairs when they have arthritis. Some of the non-surgical treatment we have for arthritis is fairly limited, but it is treatment. We oftentimes recommend patients losing weight, conditioning, exercise, and physical therapy. This is effective, but not always possible for patients. A lot of times when you have arthritis, it's hard to lose weight. And so it's not sometimes always realistic. Canes and wheelchairs can be used also. These are effective, but most people don't want to live their life using canes or in a wheelchair for sure. So it's not really compatible with a good quality of life. Oral anti-inflammatories such as aspirin, ibuprofen, Aleve, etc., and Tylenol, these have some benefit, but the side effects can mount up, and they really only give a partial relief to arthritic pain. They don't cure, they just hide it a little bit. And I'd say only a little bit that most patients feel they only get a 10-20% effect at most. Steroid injections can often, similar to anti-inflammatories, they can oftentimes cover up the pain. It's quite variable. Some patients get great relief for a couple months and some patients don't get any relief at all. It's frustrating from my perspective, but I use it as a courtesy for patients who just want a little bit of relief for a brief time. I don't think it's curative. I generally don't recommend it, but it is a strategy if one wants to avoid surgery at all costs, I suppose. Hyaluronic acid injections, this is the general term. It unfortunately goes by the name of this rooster injection. I've never quite understood that, but there are injectables that you can put into the knee specifically and technically into the hip, but mostly into the knee. I have to say, unfortunately, it's scientifically not validated. There's quite a bit of marketing behind these, and you'll hear different perspectives from patients. And there is a large placebo effect. Some patients do get relief, but it's probably placebo, and there's really not science behind this. And so I basically don't offer the hyaluronic acid injections, and you'll note that most insurance companies don't pay for it either because of this lack of scientific backing. Vitamin supplements are a favorite for patients. I hate to inform you all that it is not scientifically validated. It's likely a placebo effect as well. I know it's frustrating, but it's probably true. Cbd and topical agents. This is somewhat the new group of pain relief agents. They might have some mild and limited benefit, but if you think about it, our skin's been evolving for millions of years to prevent bacteria and foreign particles getting inside of us. And so it's unlikely there's a biologic mechanism that these agents actually get inside of us and have a biologic mechanism. But there's a little downside. They're safe. They cost a little bit of money, but it's okay with me. And patients have told me that there's some benefit. So I'm hopeful for these things, but they're probably not curative. Similarly, PRP and stem cells, cartilage regrowth, these are branded under somewhat experimental strategies. There's promising research in this field, and we're all hoping that someday we'll figure out how to cure arthritis and regrow hair and turn back time. But right now, it does not have scientific basis. It is not really proven to be of benefit, despite a lot of the marketing. And it's actually quite expensive too. A lot of patients tell me when they finally come to the point where they accept that they need a knee replacement or hip replacement, they've already spent $4,000 or $5,000 on what I think is an unscientific treatment. But that's just my opinion. I think it's a scientific opinion. I know that there will be other people that will disagree with me. Some surgeons and doctors swear by it, and I would just say be careful. Arthroscopy is something that we also talk about knee arthritic treatment. Arthroscopy is really only a surgery that addresses meniscal tearing and some other ligament injuries. It does not address knee arthritis. It's not considered treatment for knee arthritis, particularly moderate to severe. That being said, there's oftentimes a meniscus tear in the setting of arthritis, and I will offer patients who have reasonable expectations with mild arthritis, if they have a meniscus tearing, I will talk about arthroscopy with them as long as they understand it's going to treat the meniscus tear. It's not going to be effective for the arthritis. And I put two examples here below, as you can see the difference. Healthy 45-year-old active bicyclist with a meniscus tear with a little bit of arthritis, they're fine candidates for arthroscopy. They're still likely going to have arthritis down the road, but they're, at least for short-term, arthroscopy is a good option. The 7-year-old with severe arthritis on x-ray and meniscal tearing on MRI, they need to consider that they have arthritis and it's not a meniscus situation. They should be considering knee replacement or hip replacement surgery options. So what is a joint replacement? Basically, it's the removal of degraded cartilage from an arthritic joint and the replacement with low friction, high strength implants or components. Modern components are titanium, polyethylene, ceramic, and cobalt chromium typically. and they can be used with or without cement. Surgery is usually about 100 minutes long. This is pretty stark contrast versus a couple decades ago where it'd be 3 or 4 hours, but nowadays it's pretty much 60, 70, 80 minutes. That's pretty routine, unless it's complicated. The surgery largely preserves the natural ligaments, muscles, and tendons. I say largely because it's surgery, there is some incision, but for the most part, we keep the ligaments. We really just resurface the ends of the bones. Conceptually speaking, that's actually accurate. So we remove the arthritic bone, keep the healthy bone, basically. And it is the resurfacing. That's probably the better word. Unfortunately, knee replacement, hip replacement kind of becomes so widespread. We basically use those terms. Notwithstanding the efforts to use elephant tusks in the 1800s, which actually was a method of replacing hips, joint replacement really started in the 50s and 60s. And it's interesting because this is not just an orthopedic issue. This is when modern surgery, modern surgical anesthesia became safe enough to be used commonly. Antibiotics also came around at the same time, so we could give antibiotics prior to incision. And this really decreased the amount of infectious complications we saw. Similarly, back in the 50s and 60s, sterilization techniques improved, so we were using sterile instruments and implants rather than potentially contaminated components. Our implants were okay, they weren't great, they wore out pretty quickly. And also bone cement was invented, or at least started to be used this time. In fact, I think our dentist folks used it first, and then orthopedics quickly realized that we could be using it inside bones. So the first generation, I touched on already, we had high infections, high blood clots, dislocation rates were common. We had prolonged hospitalization, long surgery, bed rests were common because we were so worried about patients dislocating in or breaking their components. Pretty much everybody got a transfusion back then. Again, this is back in the 50s, 60s, and 70s. I wasn't around then, of course, but this is what I hear about. And massive blood loss. It was a pretty difficult surgery. Prolonged healing for many months was the usual. In fact, there was a letter from John Charnley, who was kind of the pioneer of joint replacement. He wrote a letter to the Queen, never mailed it, but he wrote a letter saying that the operation was too fraught with complications and dangers that he was going to recommend that England not actually perform the surgery, but he was talked out of it, and the rest is history. The earlier implants were weak. Metals and plastics was the best they had back in the day, but they were weak. They wore out in 10 years. The plastic components wore out in 10 years. And the math of joint replacement just didn't heavily favor for surgery. So the saying was, wait until you just can't live anymore before you choose surgery. You had to have a pretty high bar to recommend surgery. The second generation, probably in the 80s and 90s, and started incorporating metal alloys, titanium, cobalt, chromium, more advanced cement techniques, and more advanced accuracy in cutting and resurfacing the bone with jigs and other devices, largely carpentry devices, but still pretty accurate. We had some enhanced surgical outcomes. This was me, joint replacement became more and more mainstream, not extreme, but more mainstream. The average of the patient, because it was more successful, it went from 80s and 90s, and essentially patients only expecting 5 or 6 years of life, to now down to the 70s, where they could anticipate having many decades of functionality. So the saying changed a little bit. It said, don't do the surgery too early, but wait until you're at least 70. So there's still some hesitation, but it was a little bit less of a concerning surgery. The third generation really was where I think it became a wonderful surgery. Prior to that, it was a good surgery, but now it's a wonderful surgery. And this really is the beginning of the concept of long-lasting polyethylene. We think of plastics as plastic, but around 2000, the plastics that we used to use, the polyethylene, became slightly modified with cross-linking. And I won't go into the chemistry behind it, but boy, it really changed from a 10-year span to probably 30 and 40-year span. And it's just amazing that we can use a component for 40 years, 30 years, and it won't wear out. So that's really where the longevity came in. Now we're putting in joint replacement, expecting them to live 30, 40 years, probably the rest of people's lives. We did start including enhanced surgical techniques, blood management, early rapid mobilization of patients rather than keeping them in the bed for 2 weeks. We got them going more and more. This decreased blood clots, improved conditioning, improved outcomes, and we just got the hang of it around this third generation. Decreased complication rate came down dramatically. Accelerated recoveries occurred. And the average of patients continued to come down. Now patients in the 60s were performing or receiving joint replacements. Patients even younger. Nowadays, with this long-lasting components, I routinely do them in 40-year-olds and 50-year-olds, and I expect them to have a very long time to walk on these components. So now this saying's a little bit more moderate. So that's the opposite. Don't wait until you're too old to get a joint replacement. Now people and surgeons are much more aggressive, and I think it's a good thing, probably because of the advances we've seen over these generations. And also, it's not just about alleviating pain anymore. Now it's about, because the components are so excellent, the surgery is so improved, we're not just taking away pain, but we're preserving function and some modest athletics as well. The latest advances, we call them the fourth generation. I guess it is the incorporation of technology in the operating room right now. Interruptive computer navigation and analysis has been around for probably 10 years. I personally do computer navigation. I love it. Robotic cutting devices is a newer technology. My partner loves it and he's fantastic at it and very promising. I'm still not entirely sold on it, but I think it's a very promising technology that I'm happy to see used more and more. And some of the other things that are not so much technique driven, but same day and outpatient surgery. Nowadays we're doing surgery in the morning and the patients are going home that night. That's good. Nobody wants to be in the hospital, but there are some downsides. I tend to prefer my patients staying one night. I just think that it's nice to stay one night. Nurses take care of you, therapists see you, then you go home clear head in the morning. But nonetheless, same day and outpatient surgery is accelerating, is more popular, and there are some good things, mostly cost savings for Medicare, which most of us don't care that much about, to be quite honest with you. There's the concept of the hypervolume surgeon. This is just my own intellectual curiosity. Centers of excellence, concept of should every surgeon do these surgeries, or should it be someone who is a center of excellence only and who does them 1,000 a year? It's something I think about, because joint replacement really is a commodity at this point. And that's good and bad. Commodities, we're all live in a free market environment, but it makes me think, is a joint replacement a surgeon still, or just a technician? And that sounds derogatory, but fact is, maybe we should be considering ourselves more as technicians, not surgeons and doctors. I prefer the doctor label, but I can appreciate some people just saying, what, I just want to be a surgeon technician, and that's okay. The most common joint replacement companies that manufacture and provide components today are really 4. There are about 10 of them really, but I chose the top 4 because they comprise, or they make up at least 90% of the components. And that's DePuy Synthes, Stryker, Zimmer Biomet, and Smith & Nephew. Company representatives are present at the time of surgery, though they're not in contact with the patient and don't take any care of them, but they are an important part of the technical research team. A couple of routine examples of joint replacement surgery as follows. So here's 3 x-rays. On your far left, there is a normal knee with joint spaces, and you can see healthy joint space there, cartilage there. But over here in the middle, look at this bone-on-bone arthritis, deformity, the legs no longer straight, bone spurs, bone spurs, bone spurs. Over here is another pattern of arthritis, but this is a person that had a previous ACL reconstruction, which is more and more common. People get ACL reconstructions when they're 25 or 30, and they end up with full arthritis when they're 50. In fact, this patient was about 50 years old. And you can see bone debris, loss of cartilage. And in fact, he even has a big bone spur here on the patella. And this is intraoperative imaging. I hope nobody's queasy, but this is the tibia jig. And this is the saw, and this is the resurfacing of the top of the tibia as part of the knee replacement surgery. And on the right, there's just a depiction, but that is the depiction of the ends of bone being resurfaced with our components. So we're not replacing the entire knee, just the ends of the bones, the painful ends of the bone. And this is the post-operative x-ray with the components in place, the limb restored, the space restored. And this is an example of hip arthritis. Over here, an artist description of the arthritis, and the replacement, another kind of depiction, cross section. This is actually a femoral head from a human body. It's probably a small white ball on the billiards table. This is an X-ray showing arthritis of both hips. And this is a post-operative X-ray showing the hip implanted. We have our cup, our ball, our stem. These are inside the bone. So we're not, this is all retained bone here. The bones are largely hollow, so this is retained bone. But that's what a hip replacement looks like. This patient had decided to go on to a second hip replacement, and they're doing quite well, of course. The surgical healing after surgery, patients typically walk immediately, oftentimes the same day, usually the same day, really. They oftentimes will spend one night in the hospital or same day, as I discussed already. They go home and they're comfortable. Usually a cane or a walker for the first week or two is required. Some patients heal quicker, and we all have superstar patients who are walking without a cane in 2 or 3 days. On the other hand, some patients take a little longer than that. So this is just the average that I see. Driving typically around 2 weeks after surgery, kind of depending if it's a right or left knee, right or left hip. And driving when you're comfortable. There's no hard and fast rules here. I always say when you're ready and you're safe, go back driving, that's fine. Similarly, back to work. When you're ready to go back to work and you're clear in the head and you're not going to upset your coworkers and get back to work, that's perfectly fine. I think it's healthy way to heal. Similarly, travel and returning to exercise should be common sense based. If patients are feeling great and you have some reasonable ramping up time, you can get back to exercises, pretty much right away, again, with some common sense. And then traveling, really there's no restrictions, but you just have to consider how long you want to wait in TSA lines and LAX. And personally, I think it's probably better off waiting a few weeks before you fly. Therapy is usually ordered after surgery. Many patients don't need it. A lot of patients do their own exercises and do very well. And so it's an option, but I don't think it's entirely necessary. And more I'm seeing people do their own exercises. For final and complete healing, most patients really require a year. Most patients are much happier well before that. But for the for the complete product, it's probably 10, 12 months. And sometimes that's, you have to be patient during the healing process. One thing that's come up recently is the direct anterior hip versus posterior hip replacement. This is a very common topic of conversation. It's a complex and nuanced comparison. I won't get into it all today. I'll just say a few things here and then leave it at that. I've assisted on many anterior hips and performed over 1,000 posterior hip replacement surgeries. I do posterior replacement surgery. My partner is an outstanding surgeon. He specializes in direct anterior replacement. He's performed many thousands over 20 years, and he's definitely the person I would go to for an anterior hip. Anterior hip appears to heal a little quicker than posterior. A little quicker meaning on the order of a couple of weeks. And when you're talking about a 30-year event horizon, I mean, that's not very significant, but it does sound nice. Anterior approach hip probably spares a little bit more muscle than posterior. I do believe that. Posterior probably has a slightly safer profile. There is some reports of, especially new surgeons, that there's an increased risk of femur fracture and reoperation with the anterior hips. And it's a published article. There's actually a few published articles, and so there's a concern about the learning curve with the anterior hips. There is a little more risk for cutaneous nerves and flexor nerve and flexor muscle damage from the anterior hip. It's a small difference. We're talking 1% versus 2%, so it's not insignificant, but it's also not a big deal. And posterior probably has a slightly higher dislocation rate. Again, probably 1%, 1.5%. So there's a splitting hairs to some degree. And the learning curve, as I mentioned, if you're going to have anterior hip, make sure you go to somebody who's done at least 500. I think learning curve is my biggest concern about this. Both have equal outcomes around 6 weeks. So to me, the difference is insignificant, but I respect surgeons and patients for choosing anterior if they so desire. Some of the new technology I touched upon. To the right here, we see what is effectively the patient with the robot or the navigator. And some of the images that we see on the screen, on the bottom right there. If you Google new joint replacement technology, you'll get a lot of different things. And some of it's real, some of it's questionable. I underline robotic and computer navigated surgery because I endorse both of these. My partner being robotic and my partner not robotic, but he does robotic surgery. And then computer navigation is what I do. The subsequent ones are typically things you find online, questionable. Some maybe they're good, maybe they're not. I'm very dubious about these things. I think they're largely marketing techniques. I think as physicians and surgeons and patients, we should welcome new technologies, but be careful about them. Make sure they have a record of safety, not just being hype, as the young kids say. To go on more of the sad topic, orthopedics has a long history of new products and techniques being recalled and stopped actually because of the safety and early failure concerns. And this goes back even my career of 15 years. Middle on middle hips were 12 years ago, everybody was putting those in, and then we had loosening and blood ions. So those had to be recalled. Hip resurfacing similarly had ions and early loosening. I'm still seeing some of these hips loosen today. This is just a picture. It's a little bit inflammatory, but it just shows all the recalled components on the market that have been recalled and no longer deemed safe. Minimally invasive surgery. We all do the smallest surgery, but the MIS actually, when it came out in the late 90s, showed, oddly enough, paradoxical increased bleeding and increased complications, largely because the surgeons were really unable to do the surgery properly because they sacrificed visualization for labeling. This goes on and on and on. So I'll just, unfortunately, if you're on the same topic, if you Google joint replacement lawsuit, you'll get a similar list of people very willing to sue and collect money because of these recalls and off-market things. So it's a sobering situation. I would just say, be careful, make sure your surgeon has experience, make sure they can vouch for the safety of the product and its reliability as well. Some of the complications, very rare. Joint replacement is one of the most successful surgeries known to man with an excellent risk profile, probably 98% success rate, which very few things in life can boast such a success rate. Nonetheless, while rare, some complications occur occasionally. Some of those complications are blood clots and bleeding, medical complications, anesthesia complications, infections and dislocations and loosening and leg lengthening and nerve injuries. And there's a whole list of them. But if you add them all up, it's pretty rare. It's probably 2%. There are some temporary things that happen after surgery that I don't consider complications, but they oftentimes occur. We don't oftentimes touch on them. A lot of times after surgery, your appetite, your energy, your sleep, these are disrupted a little bit. Some people urinate a lot, have bowel pattern disruptions. These all come and go and they pass, but it should be noted. Incisional pain, there's typically some soreness at the site of surgery. We're pretty good at controlling pain these days, but there is some discomfort. There's no way around that. These are all usually benign things, normal healing and resolve in a couple weeks. Some frequently asked questions that patients ask me: am I doing damage remaining active on my arthritic joint? The answer is no. You might hurt yourself and you might hurt the knee, or it'll be painful anyway, but the mechanics are going to do what they're going to do, basically. If you already have an arthritic joint, it's going to be arthritic either way. So I would actually recommend staying active, keeping the muscles conditioned around the hip or knee or shoulder for that matter, staying active and taking a little bit of discomfort if it means you stay conditioned. Can it damage the implanted joint? Very difficult to do so. You really have to have a major injury, such as a motor vehicle accident. And so that's why I say common sense. If you just use common sense, you really shouldn't have to worry about injuring the implanted joint. They're very strong components. Does airport security detect implants? They do, actually. About a third of the time, patients will be dinged or they'll be detected. But it's a very common scenario. The TSA waves a wand, you show them your incision. It may be a delay of a couple minutes. I've never heard a patient saying it delayed them more than 5 minutes. Can I shower after surgery? You can. Probably should keep the dressings and the incision as dry as you can, but you can shower after surgery. Can I run after surgery? Running is probably the one thing I recommend against. I think it's a high impact load. And you want these components, these beautiful devices to last for 30, 40 years. So you can exercise, you can hike, you can live, and do whatever you want for the most part, but I think running is probably one impact load exercise I would recommend against. Will this surgery make me a better tennis player, skier, surgery? So somewhat of a joking question, but some patients do have the misperception that if they have a hip or knee replacement, they'll all of a sudden start running their miles quicker or go back to the double black diamond skiing. No, these components are great. They're supposed to take away your pain. They do a very good job at that. And you can be active and you can be an easy tennis player, a non-competitive skier, but you're probably not going to be, winning matches from professional perspective. Should I go forward with joint replacement surgery? question I always try to put back to the patient. We can offer our services, we can show x-rays, we can talk about the diagnosis. In the end, it's the patient's decision. And I get the sense I felt for years that patients know when they should do it. And so we offer our services, but in the end, the patient has to sleep on it, think about it, talk with it with their family. Make sure you do your due diligence. But in the end, it's a fantastic surgery. And I do recommend patients strongly consider it. Oops. This is pretty much the end, but I just wanted to touch on a few things here. You know, St. John's this is my one promo piece. St. John's is an excellent health center, excellence in surgery, anesthesia, nursing, physical therapy. Facilities are great. The outcomes are great. Even the cafeteria is great. I eat there more than I should. And myself and Andy work at the Center for Hip and Knee Replacement along with the other lovely staff and support people. There's a long history of world-class community care with Moreland, Dr. Mata, Dr. Young, Dr. Earhart. I'd like to thank myself and many others. Really a long, wonderful history of St. John's for joint replacement surgery. And if you're considering joint replacement surgery, we'd be happy to care for you. I think you have a phone number here, and I thank you all for your time. And if there are any questions from the audience, I'm happy to answer them if I can.
Dr. Bengs, we do have a question so far. It is, I'm 63-year-old female and I've been playing soccer for 20 years. I have hip arthritis. Ugh. If I had a hip replacement, will I be able to play soccer after surgery?
Should I highlight myself or should we just keep me small?
I think I see you large right now. So
okay. You know, it's playing for 20 years. That's wonderful. Personally, it kind of like goes back to the last question I ended with. Should I have joint replacement surgery? I feel like if patients are still participating in soccer, things like that, full court basketball, I've got some runners that, you know, really need to continue running. They're passionate about it. Some of my surfers are passionate about it. I say, you know what? Don't do the joint replacement yet. When you're ready, come on back. We'll take care of you. But if you're playing soccer at a good level, routinely and actually running up and down, I'd probably wait a little bit. Not that you couldn't do well with a hip replacement, you probably would. But my personal feeling is that if you're not willing to give up a couple of things, maybe you want to go slow on that one.
Thank you. If we have any other questions, well, she said, love that answer. Thank you.
Sure.
Are there any other questions? We'll give you a minute to think about it. And if not, we'll conclude, but we'll watch the question and answer box for a moment. And if you aren't familiar with Zoom, if you just put your cursor over your screen, you'll see the Q&A box down at the bottom. You click on that. Oh, there we go. How is MIS done? And I'm imagining that's minimally invasive surgery.
Yeah, thanks, Paula. So MIS is minimally invasive surgery. That was a moniker or marketing acronym, I believe, back in the mid-90s. And the concept was don't do excessive surgery. It seems so obvious nowadays, but when it first started, joint replacement was a little bit of an exploratory surgery. And so we would have incisions very long. We would unnecessarily dissect out things that we shouldn't probably go near. As we got better and better with things, we got smaller and smaller, not just for the incision size. It's actually more important with the deep aspect of the incision. And so that's a good thing. The minimally invasive surgery has overall been a very good thing. However, when surgeons historically have done too small of incision, or for that matter, let's just say plainly, got too fancy, we actually found there's a higher complication rate. So we meaning the community of orthopedic surgeons, there's a little pendulum back and forth. And most of us feel like we should certainly do not excessive surgery or dissection, but you also don't want to try to operate through, you know, a tiny hole. Even the best surgeon in the world is going to have some difficulty with that. So it is not a distinct type of surgery. That's one thing that people think. They think MIS is something separate. Totally not separate at all, despite the marketing that you're going to hear from surgeons and doctors. It's just the concept that you're going to decrease the amount of dissection, which we all do. We don't always market it. We don't always call it that, but we all, of course, do the smallest surgery but we want to do the safer surgery as well. I think David Johnson had a partial knee replacement. I think you just want a general answer to partial knee replacement, David. I like partial knee replacements. I don't do a lot of them. My feeling is that when knees become arthritic, it's not just a focused pattern. Most of the time, if you look around thoroughly, the rest of the joint is involved. May not be as involved, and there's you can have a concentration in, say, the medial compartment. But I prefer to take care of it all at once. It gives me a little bit more liberty in recreating the straightness of the leg. So I tend to do total knee replacement surgeries, but partial knees are great. My partner does them well. They have a good track record. They have some concerns like anything. So I endorse them. Just be careful. What about the other fancy aspirins besides ibuprofen and Aleve? I honestly don't think there's a difference at all. I think chemically speaking, there's probably 15 fancy aspirins, as you say. Aleve, meloxicam, Voltaren. Some of these are brand names, some of these are generic names. There's a whole bunch of them. There's a whole industry behind anti-inflammatories. I think that they don't really work that well. Some people swear by them. There's probably some slight differences between the products. I don't think there's a significant clinical difference. Jill Stein has another question. Do you really think there's any PT out there that can honestly help with discomfort of hip arthritis? No. PT, physical therapy, vitamins, none of these things are going to cure hip arthritis, or for that matter, knee arthritis. However, by general conditioning, losing weight, etc., being healthy in general, you can take a little bit of the strain off the arthritic joint or knee. But no PT, there's no magical. I know we live in Los Angeles, I get it. Everybody's a kinesiologist, everybody's a alternative medicine, that's fine, but we should state definitively that does not cure hip arthritis or knee arthritis of severity. Makes you feel good, that's fine, but it's temporary and doesn't cure it. Sorry if anybody, sometimes people love their therapist so much, I don't want to offend anybody, but I have both hips done very well, but doctor says you can't fix patellas, which are both very painful. Well, I struggle with patellas. I do hip and knee replacement. I also take care of patellas. Sometimes I resurface them, sometimes I don't. Sometimes I choose correctly, sometimes I don't. Patellas are typically replaced today in Los Angeles and the country. I went for years not resurfacing them, but there's been some concern nowadays if most patients do well without resurfacing the patella. I think that's what you're talking about. But if they still have some discomfort, it's very easy to go back in and resurface the patellas. Unfortunately, if you already had the patellas resurfaced, then that becomes a little bit of a difficulty. I don't know your specific situation. If both my hips are really bad, is it possible to get them replaced at the same time? Yeah, you'll find some replacement. I recommend doing staged. One hip or knee replacement surgery, do it well, get healed, stay focused, and then do the other one 2 or 3 months down the road. There are some surgeons, some patients that do it at the same time, hips and knees. I'm okay with that. I personally am a little more conservative. I just think that we should not get too fancy, to use the word again. So, sorry, Jill. Can you please address osteoporosis in the hip, femoral issues, and hip replacement? Oddly enough, osteoporosis has very little bearing in joint replacement surgery. It's technically important for us because if we have a very osteoporotic hip, we'll be careful not to break it. But actually the components, the titanium components, the stems, they're all designed to accommodate the volumetric changes, change the morphology of the proximal femur. And so it is not really a concern from my perspective. If it is a concern, and some surgeons will just cement it in, and there's no downside to that whatsoever. So osteoporosis, oddly enough, really has very little bearing on the hip replacement surgery itself. And then I'm a former hockey goalie with bad knees, but I'm in my early 30s. Would you recommend I consider knee replacement? Anonymous, it's a tough one because 30 years old is pretty young. And if you came in, you're 30 years old and you were bone on bone arthritis, terrible x-rays on a cane, I would absolutely offer knee replacement surgery. If it just bothers you from time to time and you're able to modify your activities, maybe back off the hockey a little bit, I'd probably wait a little bit. Knee replacements are great, but for young people, 30 is pretty young. I've done it in teenagers if they need it, but I have a pretty high threshold to sign up for that. So just be careful. All right, I've bored you all enough. I've answered your questions. Thank you. Oh, Enrico. Oh, I remember it's meloxicam. Yeah, there's a whole bunch of ones. Celebrex, meloxicam. I'm totally okay with both of those. Just listen to your stomach. If your stomach's happy, fine. If it's benefiting you, great. On the other hand, if your stomach's a little bit upset because of pain medication, anti-inflammatories, and most importantly, if it's not helping you, then don't do it. So I think it's a good thing to try. I personally wouldn't want to be on anti-inflammatories for more than 6 months or so because of the cumulative health risk, but it's done all the time.
All right.
Bacchus.
We got to thank you there. And oops.
Thanks, Andrea.
Oh, wait, we have
We're going to
one
put a
more.
picture of you next time.
We have one more about glucosamine, chondroitin, or fish oil. Can it help with prevention?
Thank you, Enrico. Anita, you're going to be upset with me because I know we all desperately want to have something oral to cure us all. But the answer is no. Glucosamine and chondroitin has not been shown. There's 1,000 articles out there, and you're always going to be able to point at one or two, and you're always going to find a patient who said, "Oh, this works great." But my job is to be a scientist and to relay that information as best I can to patients, even if they don't want to hear it. So no, vitamins cannot cure arthritis. They do not prevent degeneration, including glucosamine, including chondroitin or fish oil. Remember, these are not FDA approved or evaluated. The vitamin industry can say whatever they want. I can put my cat's hairball on something and put a label on it saying this will cure everything from baldness to joint problems, and I can legally do that. So just be careful. It's also not cheap. Some of these things are expensive because you take them for years and years. So people do become attached to their vitamins, and I don't want to upset anybody, but my job is to be honest, and they don't do anything. Sorry.
All right, last chance. 5 seconds.
Thanks, Connie. That was enjoyable.
Hey, everybody. Thank you, Dr. Bengs, and thank you to our audience for joining us tonight.
Bye, everybody.
Stay healthy.